and welcome to another ICS Impulse video. I'm Wendy Crumley-Welsh, the product manager for ICS Impulse, and today we're going to be talking about Shimp, Suppression Head Impulse Paradigm. Shimp is part of the VHIT module. So again, Shimp stands for Suppression Head Impulse Paradigm. What is Shimp? Shimp test provides additional information about the vestibular ocular reflex system, especially useful in patients with bilateral loss. The purpose of the test is to identify if catch-up saccades are present or absent. How is this different than head impulse test? Well, in head impulse test, we use an earth-fixed target, meaning the target is on the wall and the patient is staring at the dot on the wall. With Shimp, we use a head-fixed target. So the laser dot, the center laser dot, is coming off the goggle onto the wall, and so the laser dot moves when you do the head impulse, moves with the head, and that is a head-fixed target. And that's the difference between head impulse and Shimp. Let's first talk about bilateral vestibular loss. Bilateral vestibular loss is rare. About 0.6 to 4% of patients have bilateral vestibular loss. The symptoms are gaze instability with rapid head movements, oscillopsia, so this means as the person walks, their horizon is moving up and down or bouncing as they're moving. It's not staying still. Imbalance and unsteadiness, and these symptoms worsen in dark. So when the patient's in a lit room or out in daylight, their symptoms are less than if they're in a darkened environment. What causes bilateral vestibular loss? Ototoxic drugs, infections such as meningitis, congenital disorders, autoimmune disorders, degenerative disorders, and it can co-occur with cerebellar ataxia such as canvas and superficial siderosis. This is not all the causes of bilateral vestibular loss, but these are the primary ones. Shimp data collection. Just so you know, Shimp is performed exactly like your head impulse, your traditional head impulse is performed. So data collection is exactly the same. Shimp analysis. Shimp analysis is different than traditional VHIT. So what we're looking at is presence and absence of saccades. That's the most important thing. We look at the 2D analysis and the 3D analysis. You have a gain graph with normative data just like you had in VHIT. You have a hex plot, which you had just like you do in VHIT, and you can also play back the data just like you do in VHIT. So looking at a normal response, the top graph up here is your video head impulse test. So for a normal person, eye and head are the same, match up, close to 1. There's no catch-up saccades, and the gain is within normal limits. For Shimp, with a person with normal vestibular function, eye and head gain, again, they lay over top of each other. The gain is within the normal ranges, but the patient will produce a catch-up saccade, an overt catch-up saccade. You never see coverts with the Shimp data. What you see primarily is overt catch-up saccades. So you can see here the person is producing a catch-up saccade. Now, why do they produce that catch-up saccade? Again, they're looking at this laser dot that's moving with the head, and the head moves so quickly that just naturally the eye can't follow as fast. So the eye is trying to follow that laser dot, it moves to the left or the right, and then the eye catches up with it, producing the catch-up saccade in the data. So this is a normal response. This is showing VOR function. Let's look at a person who has abnormal vestibular function. So on both the left and the right side, VOR is low. Left side is worse than the right side, and you can see that in the gain. Left side is worse than the right side, and both sides, they produce catch-up saccades, and this is your traditional video head impulse test. So catch-up saccades and low VOR. For Shimp, what you see here is that the left side, could there be some function here? Maybe. But if you look at the right side, there's obvious function. Look at these beautiful catch-up saccades. So the VOR is still low, the gain is still low, just like it was in VHIT. But for Shimp, they show that they can produce some catch-up saccades on the right side, and what this is telling us is that right side has some function left. The left side is questionable. So Shimp interpretation, again, catch-up saccades, the present or absence of them is very important. Catch-up saccades that are present indicate vestibular function. No catch-up saccades present indicate vestibular loss. And the other thing to know is that there's no covert saccades. So this makes doing the gain calculation very easy. So If you have a lot of covert saccades, even if it's a unilateral loss, you can always perform Shimp and double check your gain. Because in V-hit we have to desaccade, meaning we have to remove those saccades before calculating the gain. In Shimp, they cannot produce the covert saccades, so therefore we don't have to remove them, so then we get a really nice gain calculation as well. So it's a good double check for even your unilateral losses. But for our bilateral losses, what are we looking for? Is it paralysis or paresis? Is there any function left? And here is the first article by McDougall, McGarvey, Hamagi, etc. In the neurology.